Hey everyone, we're back with another specimen. This is number 809 in our collection. The heart would have sat roughly in the chest like this, anterior surface towards the screen, posterior surface towards the turntable, inferior surface here, superior head up here, left over here, and right over here. So first, let's do what we always do, which is identify the right atrial appendage, externally at least. And here we've got an atrial appendage that appears to be triangular, broad-based, or pyramidal in shape, so consistent what we externally would think to be a right atrial appendage. So let's go ahead and open up the heart there. And when we do that, we do see pectinate muscle spilling outside the confines of the appendage, and over here too, consistent with a morphologic right atrium. When we look at this right atrium, we do see that the oval fossa appears to be intact. There does not appear to be an oval fossa interatrial communication. And then we go ahead and we find the coronary sinus here, or the mouth of the coronary sinus, I should say. And obviously, important whenever we think about the coronary sinus, that we also identify the associated structures, which are the tendon of Totaro, and then the tricuspid valve, the right-sided AV valve here, I should say. We haven't confirmed that it's tricuspid at the moment. But the right-sided AV valve, the coronary sinus, and the tendon of Totaro, in most hearts, is going to form what we call the triangle of Koch. And it is at the apex of this triangle that we would expect to find the atrioventricular node. So in this heart, we would expect the AV node to sit here. Now we look at the right-sided AV junction. We do see a valve that has 3 leaflets. So here's an anterosuperior leaflet, here's the septal leaflet, and here's the inferior leaflet. You can see that there are septal connections consistent with a morphologic tricuspid valve. When we look at the ventricle itself here, we do find coarse trabeculations. We find a septomarginal trabeculation that does have its cranial and caudal limbs, consistent with a morphologic right ventricle. And once again, here's a tricuspid valve. Here's the anterosuperior leaflet, septal leaflet, and inferior leaflet here. Now, when we take a look at this heart and we look at the RV outflow tract, we do find that there, in fact, is a intraventricular communication here. You can see there is fibrous continuity between the tricuspid valve and the mitral valve here on the other side, consistent with a perimembranous defect, but this also lives or extends into the Y of the septal band, or put otherwise, between the cranial and the caudal limbs of the septomarginal trabeculation, consistent with a perimembranous defect with outlet extension as well. And when we look into this intraventricular communication, we find this right here, which in fact is a right leaflet of the aortic valve. So we can see that there's actually prolapse of the right aortic valve leaflet into this perimembranous intraventricular communication with outlet extension. Now, as we go up the right ventricular outflow tract here, we do see that there's a significant amount of narrowing here in the outflow tract itself. And here's the outflow tract here by this muscle that supports the RV outflow tract. This is the pulmonary infundibulum, or some people will call it the subpulmonary conus. Nonetheless, I'll call it the pulmonary infundibulum. So there is hypertrophy of the infundibulum. So far we do have a intraventricular communication. We've got an overriding aorta with a prolapsing right cusp, and we've got a hypertrophy of the pulmonary infundibulum, all consistent with Tetralogy of Fallot. Here we find a semilunar valve, and remember, it's important to remember that the semilunar valves don't have a true annulus. The oval or circular structure that we associate with the annulus is a man-made structure, and it is helpful clinically and echocardiographically. That structure is better probably called the geometric basal ring, because a true annulus here is actually semilunar in shape or crown shape, as the semilunar valves have these interleaflet triangles, which are myocardium, that interpose between the fibrous valvar leaflets. Here we see that this valve does have a completely muscular support. There's no fibrous support to this. And this valve does have 3 leaflets, 1, 2, 3, with 3 distinct sinuses. This does appear to be a pulmonary valve. We see the pulmonary trunk giving rise to right and left pulmonary arteries, and there's no coronary arteries that appear to arise from the sinuses of this valve. So this, in fact, is the pulmonary valve. Here's the pulmonary trunk. Here's the left pulmonary artery, and then the right pulmonary artery coming off here. All right. Just to kind of demonstrate that better. All right. So now let's go to the posterior aspect of the heart. And here is a little bit of the left atrial appendage. Sorry. Ugh. Here is the left atrial appendage. When we open the left atrial appendage up, we do see the pectinate muscles, and we find that the pectinate muscles are confined within the appendage itself. Now we find the left-sided atrium here. It does have a smooth vestibule. We can see the horns of the oval fossa. We see that the oval fossa is intact, as we had seen before from the right side. So in fact, a morphologic left atrium. And then we do see a left-sided atrioventricular valve. This valve has 2 leaflets and no connections directly to the ventricular septum, consistent with a morphologic mitral valve. So here is the anterior leaflet, and here is the posterior leaflet of the mitral valve. And we can see the papillary muscles here and here. All right. When we look at this other ventricle here, there are fine crisscross trabeculations consistent with a morphologic left ventricle. And now we can see the ventricular septal defect from the left-hand side. Here is the ventricular septal defect. We can now better appreciate the prolapsing right leaflet of the aortic valve as well. And remember, because the aorta is overriding, we were able to see this from the right-hand side as well. So here's the aortic valve. We can appreciate that there is fibrous continuity between the anterior leaflet of the mitral valve and the fibrous valvar components of the aortic valve, which obviously is the usual. And we see the 3 leaflets of the aortic valve here, 1, 2, 3, with 3 sinuses, 1, 2, 3. And once again, we can appreciate the prolapse here of that aortic valve cusp. Now we find the ascending aorta here. Why don't we go view it from the outside? Here is the ascending aorta. Here's the transverse arch. And then here is the descending aorta. So here we do have a heart with Tetralogy of Fallot. And he'll be a slightly controversial statement, but put otherwise double outlet right ventricle with a subaortic intraventricular communication with pulmonary stenosis. So in my mind, Tetralogy of Fallot is exactly that, and that makes it a phenotype or a subset of double outlet right ventricle. Now, obviously, there are those people who describe that double outlet right ventricle and Tetralogy of Fallot differ by whether or not they have aortic infundibulum or not. And remember, aortic infundibulum would be here, and what we would see is that there would be muscles separating the anterior leaflet of the mitral valve from the fibrous valvar components of the aorta. And on the basis of that structure, some would argue that this would either be tetralogy or double outlet right ventricle. But to me, it seems like surgically and developmentally that there's really no difference between the two, and that we have found something to try to make the 2 separate entities. In fact, that tetralogy is likely a subset of double outlet right ventricle. Once again, we'll look at the phenotypic components now. Here's the tricuspid valve. Here is the intraventricular communication. It is perimembranous with outlet extension. Perimembranous because there is some continuity between the tricuspid valves and the mitral valves. And it has outlet extension as it extends into the Y of the septal band. Here's the septomarginal trabeculation. Here's the cranial limb, caudal limb, making the Y. Here is prolapse of a leaflet of the aortic valve. There is an overriding aorta. And then here's the infundibular, the pulmonary infundibular hypertrophy, which is leading to pulmonary stenosis. So, tetralogy of Fallot.